Good morning, everyone. My name is Roberto Yunes. I'm a senior health economist at the World Bank Institute, and it's a pleasure to talk to you and present something about the economics of the right to health. This webinar is part of a series of webinars that the World Bank Institute is organizing in collaboration with WBI's Institute. So I urge you to look at the WBI's website and the Institute's website and see what are the other webinars that are coming. Some of them might be of interest to you. I've been asked, and I understand that there was a lot of discussion during the course on the basics of health economics on the issue of the right to health. So I was asked to present a little bit about what are the economic principles, what are the economics behind this. So I will start. The objective of this presentation is to discuss what are some of the basic principles of the right to health. I think it's important to clarify what is behind the idea of the right to health, discuss what are the implications of the right to health for the health sector and for countries in general. And specifically, the idea of this presentation is to relate these principles to some key characteristics of the health sector and economics. So the idea of the concept of the right to health appears quite some time ago, actually, when WHO was being created just right after World War II. And it is in the constitution of WHO, the World Health Organization, it says there that achieving the highest possible standard of health is a fundamental right for every human being. So this was present quite some time ago and is one of the key elements of the general principles that have guided WHO since its inception. Not only the idea of the right to health was present in the constitution of WHO, but it was also present in the Declaration of Amata. If you know, it is the declaration that countries have made in 1978 enforcing the principles of primary care. But it's not only present in documents. It's a key element that is present in the process of democratization of countries in general. And if you think about the spring, the Arab Spring, this was also there. Another document that the idea of the right to health has been discussed quite fully is it's what is called General Comment 14. More recent is 2000, and I will get into that a little later. The main document that presents the concept of the right to health is the International Covenant on Economic, Social, and Cultural Rights. This document its enforcement began in '76. And it has been actually ratified by more than 150 countries. In its Article 12, this document says that the countries that have signed this document recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. So it's very similar to the principle that was present in the WHO Constitution. And I guess the question that everyone asks when one thinks about this Article 12 is, does it mean that this principle, and when a country signed this, Is it saying that the government will have to provide every single everything that is available for every citizen all the time? Does it imply that? That's the question, I think, that is behind many of the issues that are related to the right to health. However, a short answer to this question, to these questions, is no. The covenant also says, and this is quite important, and some people forget this, that what the covenant says is, it says that countries should take steps, and not only countries in isolation, but with the help of international assistance, and this, it is to take steps to achieving these rights given its resources. And this should not be done, and the right to health is not expected to be achieved or fully realized immediately. Countries have to move towards the realization of the right to health progressively. So it's a process, it's a dynamic process. The same general comment, the general comment that I mentioned before, the general comment 14 was specifically done to discuss Article 12. So in general comment, it tries to clarify the ideas behind Article 12, that is, the right to health. And so in general comment 14, it reinforces the idea that the covenant, what it says, is the right to health is to be progressive realized, and it acknowledges, recognizes the constraints of resources that country faces. General comment 14 says that countries are, in fact, even though recognizing these limitations and that the right to health is to be achieved progressively, it says that countries have an obligation to continuously move as fast as they can and as effectively as possible towards the full realization of the right to health. What it means is that countries cannot go back in terms of rights, cannot remove rights, and countries are required to move as fast as they can towards achieving those goals. They cannot say, oh, we can only achieve those in 1,000 years or so. They have to do the best as they can towards achieving those goals. So it's also important to note that General Comment 14 also points to the fact that in the covenant, in Article 12.1, the covenant recognizes or takes into account the biological and socio-economic preconditions of individuals. What it means is that it recognizes that not everyone is biologically equal and that societies are not equal. So there are some individuals or some citizens in every country that are in worse off conditions socially and economically than others. So this is recognized also in the Covenant on the Right to Health. So what does that what are the implications of the concept of the right to health that I presented before? So it means that behind the idea of the progressive implementation and continues and is effective effectiveness of treatments and interventions is also behind that idea, behind the concept of the right to health. And the concept of equity is also there. When we, in the previous slide, when I mentioned that comment 14 recognizes, says that Article 12.1 recognizes the differences in socioeconomic conditions. It is thinking about equity. And also, it recognizes that there is a time dimension. So this is a dynamic process. It's a process. And it also recognizes that it also implies that resource constraints means that countries will have to set priorities. And then all the things that you saw during the course, the instruments that you've learned through the course, the instruments such related to economic evaluation, cost benefit, cost utility, and cost effectiveness analysis, all of these instruments are quite relevant and quite are required when one country wants to implement the right to health. So these instruments have a direct relationship to the implementation of the right to health. Another instrument that you saw during the course that is relevant for this is benefit incidence analysis. So when you're discussing, when you're analyzing who is benefiting from subsidies and who's paying for what services. So this is quite important also to ensure that the right to health or the progressive realization of the right to health is being pursued by any given country. Another element that is, another tool that is required, that is important for the analysis of the right to health, is the principal agent theory. And this is some of the things that I'm going to discuss in a little more detail in the coming slides. Essentially the rest of my presentation is going to focus on this issue, which I think is quite interesting, and I think will bring something new for you guys. So, in summary, the tools you have learned in the course have a direct relationship for the implementation of the right to health in your countries. So as I said, I'm going to discuss a little bit about the principal agent problem, and this is how it relates to health and the right to health. If you remember in your discussions in your one of the first few sessions of the program, you learned that the health sector has some specific characteristics, and one of those is that there is a symmetry of information between the patient and the physician and those that are making decisions. So the patient has some idea what problem or health problem he or she has, but he seeks somebody else that knows better and can explain what are these symptoms and these things that he or she is feeling. Another important characteristic is that the consumption of health care occurs in a context that is out of normality. It occurs when we're sick most of the time, right? Except when we're doing our preventive exams. It occurs when somebody's not feeling well. So these two characteristics or two elements have very important implications. The first one is that a basic and essential principle of economics is violated in the health sector quite frequently. And that principle is that consumers are fully informed agents. They are very rational also. They're not only fully informed of everything, but also they are very rational, are able to take very rational decisions. However, when somebody is sick, particularly very sick or very ill, decisions may not be fully rational. They are taken in a very emotional context. The asymmetry of information means that there is an implicit relationship of trust between the patient and the doctor. The patient likes to believe or believes that the only concern of the physician is the patient's best interest. So when you and I go to a doctor, we hope or we believe that the doctor, his or she or her only interest is our best health. So If we believe in that, or because we believe the doctor knows best, we delegate to the doctor the task of ensuring our physical or mental health. And that's the essence of an agency relationship. We, the patients, are the principals. We delegate to someone, in this case the doctor, who is our agent, the responsibility and the mandate to take decisions on our behalf. So we're saying, okay, doctor, do whatever is best for me. This is essentially what is going on. It's also important to notice that this relationship between the patient and the doctor can be replicated or thought of in the more aggregated context between the citizen and the state. The citizens of any country delegate to the state the responsibility of ensuring our well-being in several areas, including health. So not only health, but also security, justice, and so forth. Sometimes in education, for instance. So there is also an agency relationship between the citizens and the governments of countries. So in that case, the citizens are the principals, and we delegate to the government as our agent the responsibility of fulfilling some of our rights. And some of these rights include the right to health. So we're delegating to the government the responsibility of fulfilling our rights progressively and as fast as it can. So here, I'm going to present to you a very simple economic representation of this patient or this principal-agency relationship. Let me start looking at from the point of view of the doctor as an agent of a patient. Here we have a graph showing this curve is the result of a medical intervention and the benefits derived from medical care. So, as you can see, this curve has a certain specific shape which reflects the fact, what is called decreasing marginal benefit, which means in the early stages of any treatment of medical care, if I provide more days of care or more services, it will provide an increase in benefit. However, as we move on along the path of care, the same increase in services will provide less benefit. So as we move on, adding another day in the hospital, maybe the first 1 or 2 days in the hospital will greatly improve my health status. But if I stay from the 10 days, from the 10 to the 11th day, actually there is, in many cases, the impact of this, the benefit of this additional day at hospital admission will be lower. So the idea of this is that there will be a point from where the benefit is maximized to the patient, and from this moment on, whatever care I provide will not add any additional benefit. It may actually decline. If you think of hospital, adding more days of hospital may actually be negative, risk of hospital infection or anything like that. So there is a point, which I call here XM, which provides the maximum benefit for the patient. However, society has a different point of view from that of the physician and the patient. Any intervention has a cost. And this cost, I'm simplifying here, I'm assuming as a straight line going up. The more care I provide, the more costly it will be. So society not only takes into consideration the benefits, because resources can be used for other purposes. So if you look at these two curves, there is a point, which I call here X star, where there is the difference between benefits and costs are maximized. This is where the social net benefit is maximum. There is another point where costs are equal to benefits. So the social net benefit derived at this point is zero. So the benefit the patient gets from that treatment is equal to the social cost of producing that service. Oops. Says that. I'm sorry, I think we're having a problem. Okay, they tell me that I can continue. However, we can assume that the point where the individual benefit is maximized can be above that point, further on the point where social costs and social benefits are the same. So they're very likely when the benefits to the individual are maximized, you have a social cost that is greater than the benefit that is provided by that service. So the dilemma that societies face is how much service should we provide? And that's the idea of the right to health and prioritization. So should society provide the amount of services that maximize social net benefit? Should society provide the amounts of services that equate social benefit and costs? So I can provide more benefits to the patient at costs up until the point where social net benefit is zero. Or should society may take a decision to go beyond, to go to the point where social costs are actually positive, social net costs. So social costs may even go beyond the benefit given to a given patient. But you might agree with me that's a less likely decision by society. So the decision maker, the government or the person in the Ministry of Health, has a decision to make. Not only he is faced by this, he realizes or recognizes the dilemma facing society between social costs and benefits, but also he's faced with a budgetary limit. Government resources have to be allocated to many different objectives, and health is only one of them. So the decision maker in the Ministry of Health faces a budgetary limit. So in this case, in this example, for instance, the budget of the Ministry of Health is below what could be provided when social costs equate social benefits. So the country does not have enough resources, so you can see the costs for where social benefits equate costs are above the budgetary limit. So the maximum that this government has in terms of resources is this quantity of services here, XP. So the decision maker in the Ministry of Health has to decide whether he is forced actually to move to this area. They can only work, given the budgetary limits, between providing zero services and XP. It cannot, according to the limits of the Ministry of Health, the budgetary limits, it cannot provide the amount of services that equates social benefits and costs. So this decision maker has to come to society if society wants to go to this point and say, sorry guys, we cannot afford this. we can only provide quantity of services below what you want to provide. But this is a conflict between what a decision maker decides and what society may decide. So if society says, no, we want to go here, then society has to say, okay, we have to increase the budget of the Ministry of Health to have enough resources to provide this amount of services at the expense of other things, of transportation, clean water, security, education, whatever. But this is a decision for society. And this is the debate that is happening, that happens quite frequently in society. And this is the debate that you guys see all the time. How much service can we afford? How much service is fitting with the concept of the right to health? What the government can argue is, at this point in time, we can only provide XP, but we are moving progressively towards the direction of XZ. So we'll do our best. We'll try to be more efficient, more effective, and more equitable, so we can ensure the amount of service that society really aspires. Thank you very much. I think now I have prepared 3 questions for you that I will pose to you, and that may help us lead in our discussions and questions that might come up. The first question that I would like to pose to you, and you can answer, is the right to health present in your country's constitution or legislation? Okay, we're waiting for your answers. What we're hearing is about 3/4, or now we're having 70% to 30% of you in your, okay, when should we stop? Okay, so up until now we're about 60% say that the right to health is present in your country's constitution, and 35% say no. The next question. Do you think that there is a principal agent problem in the relationship between the physician and the patient? What I mean by this question is, can patients trust the physician? Is there a problem there? If we cannot trust the physician, you say yes, there is a principal agent problem. If you think patients can trust the physician, meaning that the physician has only the best interest of the patient in mind, your answer is no. So what we can see from your answer is that the vast majority of you believe that physicians have other things in mind when taking decisions for the patient. The final question that I would like to ask you is, if you are the decision maker in your country, maybe you are, and if you were to decide what is the amount of services to be provided in your country, where would you, until what point would you go? Where social net benefit is equal to 0, and this is what it seems that we're getting as an answer, where social benefits are maximized, or where the benefits of the patient are maximized. So it seems that we have, now we have some divergency. That's interesting. oh wow, this is quite interesting, fascinating. So we have about 40% of you saying where social net benefit equals 0. So where social benefit equals, where social costs equal the benefit to the patient. About a third of you believe that where social benefits are maximized, so even a little below, what the patient can benefit given existing resources. And actually now we're getting that almost 40% believe that where the benefits to the patients are maximized. Interesting, very interesting. So, okay. I wonder, is there any questions that you may have for me, and any discussions that you would like to continue? What I think is that what I'm hearing from you guys is that the benefit to the patient is quite important, and even a country should pursue the goal of maximizing the benefit to the patient, even at the expense of other sectors and other resources. The countries in general and societies in general may move beyond what is the social maximum benefit. And this is, societies believe, okay, if we have resources, and this is commonly seen, for instance, in the AIDS case, in many countries, when countries decided to provide full antiretroviral drugs for patients, even if that decision was not the socially optimum, societies have decided, let's go ahead with it. This is a problem. It's a situation that deserves attention, deserves additional resources. So even if it is not, we're not maximizing benefits, we should move ahead, and even if it implies additional resources. In my country, for instance, Brazil, there was a law approved that saying it's the only disease that has a specific law saying that AIDS should be given for free for all individuals. So this was a social decision. Society was willing to pay any costs for treating AIDS patients. Okay. I have a question. Somebody asking, is there a country that has reached at least 80% of the right to health? Good question. What is 80%? What is 70%? Whatever. One can think of societies that have moved further towards providing or reaching the goal of the right to health. And I think obviously these are the more developed societies, possibly Scandinavian societies. The US is far from there, as you know, for instance. So it's a goal, it's a struggle for any society. Somebody is putting a question saying it would be interesting to see how answers would vary, if I understand your questions, based on the economic power of countries. Interesting. If you mean economic power by the level of development, yes, you're absolutely right. I think it would be quite interesting to see whether those countries that are poorer, whether the answers will be different that are more relatively well-off countries. Um, um, any other questions that you may have? There is another question saying, of the African countries that have made significant progress in health, where on the graph would they be? Did they invest in health where total benefit were greater than total costs? Good question. I think this is a question that is hard to answer, and I think the answer to this question, you would have to use the tools that you've learned in the course. For instance, you have to think, is the health sector in this country efficient? Are resources being wasted? So if resources are being wasted, it means that there is some leverage for the country to increase its resource allocation. The amount of services that are being provided, despite the low income context of some of these countries. It's hard to I don't total benefits are above total costs. Somebody's asking, when can we say that the country respects the right to health of its citizens? I think the answer to this question is, if we can demonstrate, if a country can demonstrate that it is moving as fast as it can, it's doing its best efforts to progressively provide services, more and more services, and more benefits to its citizens, I think we can say that the country is respecting the right to health of its citizens. It doesn't mean that the country has to provide everything to everyone. However, if the country is not inclusive, for instance, and accountability, all these things would imply that the country is not respecting the right of health of its citizens. So it's more than only providing care. It's for whom this care is being provided, whether the country are using to its best all the resources that it has at its disposal. So if the health system is very inefficient, there's a lot of corruption, and resources are being wasted, one can say that the right of health of its citizens are not being respected. There is another question saying, the concept of market failure in healthcare has been brought up in course. Yes. Is there any solution to the market failure? No, there is no easy solution. Countries and health systems have tried, and actually, in the end, the organization of a health system is an attempt to solve these market failures. For instance, in the US, all these litigations for uh, inappropriate care is an effort to respond to the principal agency relationship problem that might exist between a patient and a physician. So in this country, the access to the courts to sue a physician or a hospital or something is an effort to these attempts these attempts to solve market failure end up forming or constituting what will be the organization of any given health system. So my short answer to your question is no, there is no simple solution, there is no solution to market failures. We are always working on a second best environment in health. There is another question. Can you think of the right to health, it should be considered as a fundamental right in countries? Yes. Yes. In my opinion, and if countries have signed the covenant on the socioeconomic covenant, they're saying that health is a fundamental right. Again, being a fundamental right doesn't mean an absolute right. It is a right that is based on the resources and conditions of the country. I think I don't see any more. Okay, there is another question. Is universal, oh, this is a very good, interesting question, a very good and interesting question. Is universal health coverage movement a solution to the right to health? Universal health coverage and right to health are very linked. So the movement towards universal health coverage is a movement towards the right to health. They are very consistent that way. So countries that are pursuing universal health coverage are, in principle, pursuing the right to health. However, there is an important difference here. On the right to health, processes mean a lot. So one country might be trying to move towards universal health coverage without transparency, without accountability, without participation, without, and maybe with some law enforcement or without respect to the rule of law or things like that. All these things are against the principles of the right to health. So universal health coverage and right to health are similar but not the same. Maybe one can say that movement towards universal health coverage might be a necessary condition towards the right to health, but not a sufficient one. So that distinction between process and goals is quite important. There is a question saying that given the issue of agency between doctors and patients, is there an argument for health systems to be financed by general taxation or national health insurance rather than private insurance, for example? This is an interesting question. I don't know whether the answer to this question has anything to do with the agency problem, because the agency problem might exist between citizens and governments, for instance. But one can say that in the private market, the likelihood of patients being involved in conditions where catastrophic health expenditures and things like that, and the principles of the market and the interests of profit, for instance, going overboard the interests of the patient, that might easily occur. So one can say, or one can think, I wouldn't say one can say, but one can think that in a pure private market, the likelihood of the right to health being achieved is less likely. I mean, it's less probable because there will be other interests may take precedent over the interests of patients. Oh, so there is a clarification that if healthcare providers and employers are paid by the state, agency relationship, but they wouldn't go away. Again, as I said, the principal agency problem might exist between citizens and the state itself. There is a question, the point where social net benefit is zero is always higher than the budget limit? No, not necessarily. It's probably true in most developing countries' contexts, but not necessarily. And this is, if that's the case, that the point where social net benefit is zero is above the budget constraint, then there is a decision by society whether those services should be provided or not. And again, so the idea of the right to health, these principles related to participation, transparency, and accountability, these are all related to the idea of the right to health. They come into play in conditions like this. Any other questions? There is a question saying, when people are unaware of their civil rights, would it be difficult for them to have to know their right to health? What do you think? Absolutely. Absolutely. That's why the concepts of transparency and accountability and non-discrimination are integral parts of the concept of rights and the right to health in particular. So being aware of your rights it's a fundamental element of the idea of the right to health. So yes, the answer to this question, yes. Do decision makers care about citizens' right to health, or is it up to the citizens to care about it? Very good question. Again, it's hard to generalize. I would say that I would like to think, at least myself, maybe I'm naive, that decision makers do have the best interests of citizens when they're making decisions. But this is obviously not always the case. And decision makers also fail when making those decisions. They take the wrong decisions. They have also different forces influencing their decisions. So no, I would say you cannot count that decision makers will be taking the interests of the citizens for granted. I think it's for the citizen to look for your rights and to make sure that they are enforced correctly. There is another question, there is another point saying literacy is related to health, and that's why poor people have more health problems than better offs. Yes, it's true. Evidence has shown that literacy is a critical element to improving health conditions. So literacy, it's a very important element of health condition, and in that sense, for individuals to ensuring that their rights are being fulfilled and satisfied. So information on the citizens' part, literacy, education, health education, general education are critical elements in this process. Somebody's asking whether Cuba is similar to Scandinavian countries in this regard. This is a very interesting question. Cuba does seem to generate some very good, excellent health outcomes. But if you think of a rights-based approach to health, including transparency, accountability, participation, and all these things, then I wouldn't say that the Cuban health system satisfies the demands of the right to health fully. There is a trade-off here between, in the case of Cuba, transparency and accountability and participation and so forth, and the right to health. So even though Cuba achieves very good health outcomes, it does not mean necessarily that the right to health is being satisfied or fulfilled in this case. And this is actually a very good example of when health outcomes might be achieved, but the right to health might not be. Any more questions? I think we're getting to the last 5 minutes or so of our. Okay, so they're telling me here one more question if there is one. Otherwise, we have to close. There's somebody typing, but I hope that this has been useful for you, and I hope you have been able to relate the concept of the right to health from what you have learned in the course, and you can see that what you have learned was not something that is abstract, but it does have a very real actually, implication on day-to-day decision-making process. So I think we have to close at this point. And I thank you very much for your participation and your questions, and I hope to see you soon. Just one final point before I forget.